All right. Since we're already a little bit late, this is a coffee table. I love it. I'm going to sit here. Since we're already a little bit late, we're pushing everything back. We thought we was going to go ahead and start. Um, how are we starting, Shawn?
So we're going to start by letting you know that we are both coming here from the D.D. Hirsch Suicide Prevention Center. And today we're going to talk about the topic of suicide risk assessment and safety planning, and talk about how you can help in the different roles that all of you might be serving in your communities and in your organizations.
And I kind of want to say that if you are here thinking that we're going to give you a super clinical, well-defined risk assessment, safety planning training, this is not the correct room. Really, this is all about trying to give you a tool to assess risk and to help support a person with safety planning in any of your roles, okay? So that's what we're gonna talk about. I wanna make sure that that's clear to everybody.
So I am Shawn Silverstein, and I'm a licensed clinical psychologist. I work at D.D. Hirsch, as we spoke about before. The lead psychologist, it's a fake title though, because I happen to be the only psychologist that works there, so I don't really know what I'm leading. But what I do manage is our survivor of suicide attempt support group, which Anne is part of, and she spoke so beautifully about. So I feel like she did the group very good justice. I also manage our training and outreach program, but it really, at D.D. Hirsch, it's kind of the village model. There are so many talented, wonderful paid staff and volunteers that all come together to provide these services for everybody. And so I'm going to tell you a little bit about my personal story and what brings me here. I'm always fascinated to learn why somebody might want to focus on something that traditionally and kind of in our society sometimes is viewed, as this dark thing, and there's this fear and shame and stigma around suicide that prevents people from talking about suicide in an open way. I was personally impacted by suicide September 26th, so almost 8 years ago. In 2010, I was a grad student at the time. I had been working in the field for about 6 years. I was at UCLA doing an internship, and I had a cousin who was very depressed. She had attempted suicide at least 4 times that I know of. And the method changed. It wasn't always the same method, but for those 4 times that I'm aware of that she attempted suicide, the result was the same, that she lived through those attempts. And I tried to help her. I felt like, I'm a mental health person. I'm going to school. I work at UCLA. I know all these people. If there's someone that can help her, it should be me. And so I certainly did that. Got her into these different programs, got her in to see therapists and psychiatrists, and really a great treatment team. Literally someone that I felt proud that my family member was seeing all of these people. However, on September 26, 2010, she ended up killing herself. And I found her dead, actually. And so it's the combination of the fact that I felt frustrated, I felt angry, I felt hurt, and I felt sad for her, and I felt sad for my family that she died by suicide. But then when you add in the kind of visual experience that I saw from her being dead and the way that she did it, that was very profound and life-changing for me. And so, and I was kind of in these formative years of being a grad student. I still hadn't received my Ph.D., and I knew that I wanted to work with people who are in crisis and people who are dealing with suicide and severe mental health concerns. And so I hope that the work that I'm doing is paying tribute to her legacy. Her name was Janie. I hope she would be proud to know that I want to help other families and other people avoid the situation that I found myself in when she died, and that my family found themselves in.
Thank you, Shawn. I'm Sandri Kramer, and I am not a licensed clinical psychologist or even a lead psychologist or even a clinician. I'm actually sort of fell into this field. My background is in anthropology and psychology. However, through my volunteering, I became the crisis line director, and I was then in that position for quite a number of years, and now I have the privilege of working on program development and grants, and as you by now know, do a lot with law enforcement training and things like that. My reason for sticking with it, even though it has been tough, one of my staff members at the time, one of our beloved shift supervisors, Brandon, he had been with us for over 10 years, ended up killing himself while he was still working with us. And that loss was really devastating, and it really made a lot of us who were working in the field say, if we cannot even save one of our own, what are we doing? And we had a little bit of an identity crisis. And as the crisis line director, you kind of are like the den mother. And I felt I had to take care of all these people, all these staff and volunteers. And we lost some people. Some people could not continue. But I learned something from Brandon's family, who really got heavily involved. As you saw earlier at the panel over here, something impacts us, and it makes us change our role. We have to do something. And they were very inspiring to me. And the fact that so many of our volunteers and staff gave them extra inspiration, it helped me stick around as well. So I'm very excited to be here to talk about all of this. So. All right, so the first thing I want to make sure we do just a little bit of an introduction on why do we even need to have this big summit? Why is this the 8th year that we're having this? Let's look and see what the problem looks like, okay? So just briefly, why? So if you look at those numbers, and really, in reality, these, obviously, you can tell that, how many people we have with thoughts of suicide on an annual basis, and how many people we have who are attempting. Those are estimates. They have to be. But if we're looking at, so the latest figures that we have data for is 2017, almost 45,000 people died by suicide in this country that we're aware of. If we're looking at what the SAMHSA Health, National Health Survey comes up with in terms of thoughts, we're actually looking at about 13 million people in any given year, serious suicidal thoughts, okay? 1.3 million people attempted, 45,000 died. I want to encourage you all to look at these numbers not just as, oh, it's sad, it's hopeless, it's devastating, but I want you to look at the difference. If we have, let's say, 10 million people with serious thoughts compared to 45,000 deaths, that's a lot of people who had serious thought and did not die, right? And if we compare 10 million with 1.3 million attempts, that's a lot of people who didn't attempt. So what happened in between? Did they talk themselves out of it? Did something change? Did somebody help them? Did they hear a story of hope? To me, these big differences represent areas of hope for all of us. What if all of us start addressing something that we really need to do, the elephant in the room, and deal with the fact that, yes, there is a lot of fear, taboo, guilt, shame, all these different things related to it. We need to just move all that away and make that elephant, even though he's beautiful, a little bit smaller, and make it so that everybody just starts talking about suicide, and perhaps we don't need to see so many deaths. Well, what would that take for us to do that? Well, you probably heard this phrase before, it will take a village, right? Here is what we're talking about. All of us live in these different circles over here, right? Schools, our workplace, our friends and family members. If in all these different environments, people will address the elephant in the room, make suicide discussable, make it easier for people to reach out for help, then we can definitely bring that number from 45,000 down to 0, which is that Zero Suicide Initiative. And you heard our keynote speaker talk about that earlier. It's all about really working together and attacking it from all these different angles, right? So that's really what we're talking about. What is the community approach and what is our role? What is our role in this setting? My school. What is my role in this setting? My church. This setting, my work environment, my family, my friends. We want you to walk away from this workshop with an idea of I can be helping somebody in whatever role I find myself in whatever setting. You ready for that? Good. Otherwise, you're not in the right room, I guess. All right, so this is an interactive workshop. So Shawn's going to talk us through it, but I want to encourage you all, keep your phones on silent, but do get them out.
How many times do you get asked to take your phone out at a presentation? We're cool like that. So I want to kind of start off by talking about how we're all going to interact and participate with this process right now. So if you look at this board, I know some of you might be able to see it better than others. We're going to ask you to text. So if you look at the screens that are up, if you text DIDISPC to the number 22333, you will join the session. And there's going to be a few different points in time during our presentation where we ask you to share your thoughts and your experience. There's one kind of guideline that will be really helpful if you kind of follow. And so when you text an answer to one of the questions that we're going to ask, if it's more than one word, it's really important to put a dash or a hyphen between each word. Otherwise, it will just think that you're typing 3 or 4 or 2 or 10 different words, and it won't convey the meaning of what you're saying. So if you think that you want to say self-care, for example, you have to type self-care instead of just self-space care, okay? So between every word. So if you wanted to say self-care is important, it would be self-care-is-important. Are we all cool with that? So DDSPC, so DIDI. SPC. S as in Sam, P as in Paul, C as in cat.
Yeah, so 22333. And the moment you send that, you'll get an automatic message that says that you've joined our session. Yeah.
All right.
Yeah? And just so you know, there's a limit of responses on there. So if you're really eager to participate and you want to see your answer up there, be quick.
So it's a competition, all right? But we don't want any fighting, all right? So we are going to ask you to participate in our first poll, and you will see the answers, okay? So I want to ask you very broadly, what are things that you look forward to? Go ahead and text your responses.
What gets you through
Anything
rough
life.
times? What gets you through the day?
It could be kids, it could be family, it could be vacation, all those things plus more.
This is really fun for us. Wow, look at that. That's
wow, that's
awesome.
amazing. So, I love some of the answers.
Sex. I had to point that one out. I just
That's
saw
funny,
it.
Sandri. That one stood out to me too.
Well,
Okay, so
nice, good.
So what's neat about this, you can see as people are sending their responses in, some responses that are getting sent multiple times kind of stand out. So we see things that people are looking forward to or that they like. In addition to sex, we're looking at family, we're looking at travel, we're looking at vacation, husband, me time. I like that somebody did the whole dash thing right there. A glass of wine. My partner. These are all fun things, right? When we have these things that we look forward to, this helps us to balance our lives. And it helps transition into the next question that I want to ask you to participate in. On the flip side, what stresses us out? Because these things kind of interact.
Kids is already up there.
Sometimes these things can be the same thing, just at different times. You know, I think someone said husband. Sometimes those are great, sometimes they're not so great.
I like that petting a cat can be a stressful thing.
If
didn't
you're
know that.
allergic, it could be, you know? I like how work just stands out.
It's family for what we love and
We
work
should
that
have
we.
had some wagers going, what's going to be the biggest word? All right, so we look and we see stuff. We see paperwork, we see work, finances, boss, time with family, patriarchy, poor communication, my son, racism, DMH. I just pointed it out because I knew people would laugh. It's funny. So we see there's a lot of things that we look forward to, right? There's also a lot of things that stress us out. And that's the point that we want you to walk away from this exercise. It's fun to engage with everybody. And there are a lot of different things that are both exciting, stressful, and sometimes can be both, depending on how they're showing up in our lives. And so we want to go ahead and discuss how suicidal thinking can evolve in a person. And we want to take a look at what happens when stressors pile up. Is there anybody in here named Bob? Please raise your hand if you are a Bob. You only get 3 seconds or else you got to suffer in silence.
Good.
All right? No Bobs? All right. Well, in that case, meet Bob. This is he. And I want to point out a couple of things on this map. First of all, notice that Bob seems reasonably happy, right? And then I want you to keep in mind that this line going forward, that represents the future. And this empty space right here, that represents all those things that we look forward to. It represents endless possibilities that people can strive to achieve or accomplish in their lives, all right? And we're going to kind of look at what happens when stressors pile up. So at DMH, since all you all said you're stressed out by DMH, you know, at work, Bob recently got a new supervisor. He's worked for 20 years at DMH, got along fabulously with his old supervisor. The supervisor retired, and they hired this young gun who came in and is one of those kind of typical know-it-alls. And he's telling Bob how to do his job, even though it's clear that the boss doesn't really know how to do their job. And Bob's getting really frustrated by this. Oh, people can relate to that. It's a common story. Relationships. Bob has 2 twin daughters who are seniors in high school, and he has a wife that he's been married to for over 20 years. Bob is about 45, by the way. The 2 kids are expecting to go to this really fancy private college, and that's going to cost a lot of money. But Bob's not really sure about work right now because there's a lot of conflict. And his kids still expect to go to that school, and his wife expects for him to make that happen. And so he's been having some conflict with his kids and his wife, talking about what if we can maybe think about junior college instead of Stanford. Okay? They are not having it. Like many people in this city, Bob has been living beyond his means and has a lot of credit card debt and still has student loan debt from when he was in college 20 years ago. And given the whole work uncertainty, he's really concerned. But notice that Bob is still happy because Bob has coping skills like many people do, and those coping skills haven't been exceeded yet. But look what happens when you add another stressor. Ooh, look at that technology. Now you see, we know how to express emotion here. So now Bob is kind of feeling like, oh, I don't know if I can handle this, right? This is a lot. It's starting to feel heavy. His daughters are hardly talking to him because they're mad about college. And he's even worried about his relationship with his wife. Recently, he's been having a lot of headaches and a lot of gastrointestinal issues. But because of his concern about finances, Bob doesn't feel like he can go to the doctor. So he's just kind of letting those health concerns sit with him. Oh, look now. This is really starting to pile up, and it's hard to see those things that we look forward to for a particular reason that I'm going to mention in a minute. But Bob had this cat for 17 years, and the cat just died last week. It's really sad. And Bob is at this point, God, I've invested 20 years of my life into this career. I've raised these kids, and it's all seeming to kind of go up in smoke right now. Who am I? How did I get here? Did I go wrong? Did I make a mistake? And he's been feeling really anxious and depressed for the last couple of months. But again, because of finances, he doesn't feel comfortable to spend any money to go to therapy. So he's holding this all in. And all of these stressors have built up. It's too much for him to cope with, and he's lost that clarity of the future. Can't see what's on the other side because there's too many stressors. And so what happens, I want you to all imagine the last time that you felt really awful. This could be emotionally or physically. The last time you had a really bad stomach flu. The last time that someone died. You felt bad, right? Now, were you thinking about all the wonderful, awesome things in your life? Or were you also thinking about how much you hate DMH paperwork and how much you think you should get paid more and why is the 405 so messed up? We tend to have what we call tunnel vision or mood congruent memory, and it's a cognitive distortion. When we're feeling bad, we tend to focus on bad things. When we're feeling good, we also tend to remember and focus on good things too. That's the good news. And so these cognitive distortions, when people are feeling bad, they start to take place. And people start to overemphasize the negative. And that can lead people to this state of feeling hopeless and helpless and not being able to balance the good with the bad. And a lot of times people then develop this unbearable pain. And in my experience working with people in crisis and people who have made and survived suicide attempts, this is almost a universal experience among people who have had that experience. Most of them do not actually want to die when they make a suicide attempt. They want to escape that unbearable pain. And so when you're in pain and it's just kind of sitting there and simmering and growing and you're focusing on all these negative things, sometimes people make this identification that the only way out is death. And that's where suicidal thinking and suicide attempts come into play. So in our role, and our role here can be very diverse. There might be teachers, there can be law enforcement, there might be psychologists, LCSWs, suicide experts. There's a lot of different people in here, nurses. When we're in the role, the generic role of caregiver, whatever that is, sometimes when we are faced with somebody who is in a suicidal crisis, this is our reaction. And in some settings, I use foul language to describe this. In this setting, I'm going to say this is my OMG face. This is the deer in the headlights face. Because you're faced with this intense experience. You don't want this person that you're worried about, this person at risk, you don't want them to die. And you're scared. And even if you know what to do, it's still scary when you're faced with someone who's telling you that they want to kill themselves. And so oftentimes, when we're faced in that situation, we live in this Prozac, Viagra world where we want to pop a pill and we want everything to be better. And we know that suicide is very complicated and multifaceted. And so sometimes we'll give them that Xanax and we'll be like, you're so smart, you're so pretty, this is just temporary, everything's gonna be fine, life is great. And these are all things that people say with very altruistic goals. They really want to help. They want to make someone feel good. They want to help alleviate the pain. But what we know from working with people and from what the research tells us, and more importantly, what actual survivors tell us, is that telling someone that it's going to be okay, you're kind of in some way reinforcing stigma because you're not giving them the space to just be in that bad place, but also to be there to support them. And so this is not blank or kind of dark for no reason. It's dark to represent that sometimes people need you as the caregiver to sit in the darkness with them and to just listen. When you can do that, when you can really truly do that, people will often let you be there and kind of be in that place when they're ready to kind of turn on the light. I have had the privilege of listening to a retired California Highway Patrol officer named Kevin Briggs. They call him the guardian of the Golden Gate. And he's brilliant. I love this man. One of the cool things about him is that he's talked to many people on the Golden Gate Bridge who are thinking about suicide. And he talks about this 80-20 rule. And it's brilliant because he's not a clinician. He is someone who became expert through experience. And the 80-20 rule is really when you're working with someone in crisis, whether it's a family member, whether it's a client, whether it's a student, whether it's someone that you're encountering on a traffic stop or who's on a bridge, you want to listen about 80% of the time, and you want to talk about 20% of the time. You really can't believe how empowering it is and how much people hold in. And when they're able to have somebody listen in a non-judgmental way, the psychological term is catharsis. You get that release. And I don't like psychobabble that much, but catharsis is a good word to describe that experience of having someone listen to you and getting the relief that comes with that. And so when we're sitting with someone in the darkness, and this is important for what I'm going to talk about later as far as safety planning goes, we really want to be able to help people identify ambivalence. And ambivalence really is referring to the fact that most people have this simultaneous desire to both live and die when they're in a suicidal crisis. Even if there's only like a 5% part of them that wants to live, most people have some part that still has a connection to life. And when we can identify the ambivalence, we can identify that connection to life, and that's going to be very important for the safety planning process.
Oh, thank you. So how do we let people know when we're not doing well? As I said earlier, it would be great if we lived in a society where there is no elephant in the room and we can just tell anybody that we're struggling with suicide. How do we let people know that we're falling apart when our society doesn't allow that, right? So, click. Reading that, it's time for another poll. Yay. So you probably know a lot about this already. How do people let us know they may be struggling with suicide? What do you guys think? Wow, look at that. Isn't that interesting? I always have to laugh at one. It won't stand out to me. I won't call it out. So look at that, guys. This is what we do. This is what we have to do in order to let people know we're struggling. I'm sure you all have heard this, and I'm sure you all have thought it secretly at some point. Oh, that person, they're not really wanting to kill themselves. They just want to get attention. Exactly, get attention. Here's what I want to say to you. Yes, they want to get attention because they don't know how else to let people know they're struggling. For somebody to have what we may call, oh, it's a half-hearted attempt. You know, they took like 3 aspirin or whatever. They knew it wasn't going to kill themselves. But the reality is that's an attempt for suicide, and that is a way to express we're struggling, okay? So wouldn't it be nice if we can change that? Wouldn't it be nice if we can no longer have to put out those warning signs? Now, I was very pleased to hear our keynote talk about that this morning. When I say warning, and those things that we just saw up there, we typically call those warning signs, right? But when we say warning, what does that imply to most of us? Danger? Stay away. But the last thing a person who is struggling with suicidal thoughts needs is for those who can help him or her to stay away, right? So with gratitude and apologies to Living Works, who put out, they're the makers of the Assist workshop that you heard about earlier as well. We teach it also at D.D. Hirsch. What if we just look at them as invitations, all right? I think that's really important. So some of you, many of you may have already done this Assist workshop, but that, when I first took that workshop myself, I was in a room full of people who were crisis line directors, and we all sat there with our arms crossed and saying, well, what are you gonna teach us about suicide? We know everything already. This is the main thing that stood out for me. Yes, let's not call it a warning, let's call it an invitation. So an invitation to what? Well, an invitation to ask, right? Find out what is going on. You all were really quick coming up with potential signals that people put out there that they're struggling with suicide. We know them. We know them. But we still perhaps didn't ask. So then how do we ask? How do we ask? Well, I mentioned earlier, what this workshop is about is, and in the past, you know, we have a slide like this for the crisis line training, and it's ask, are you thinking of killing yourself? Because that's what we're supposed to do on a crisis line. But the reality is that can be hard, and the Columbia Lighthouse Project put together the Columbia Suicide Severity Rating Scale, the C-SSRS, and it's the most evidence-supported tool of its kind. It's really simple to use, and right now, through a project called the Mayor's Challenge to prevent suicide amongst military veterans and their family members, we're looking at using the screener version of the C-SSRS widespread throughout LA County, so that all of us in our various roles can use it. And it's very simple, and that's what we're talking about teaching you, and that's also what those community cards are about that are on your table. But how to ask is difficult if we don't first look at what is it that is preventing us from asking, okay? So that's our next poll. If you look at this, and you can pick your top 2, if there were times in your life that we heard some survivor stories, right, this morning, people didn't ask. Why do people not ask? So pick your answers there and see why people do that. It's nice to see all those changes happening in life here. Yeah. And it will probably continue to change until the survey says, no, it's full. The reality is, any of these things have happened to us, will happen to us again in the future, and then we feel bad about it. Because we all have that instinct that we knew something wasn't right, but we decided to not follow through on it. But I think a really big one is, you see that over here. Not only, I didn't know something that serious was going on because we don't live in a society where we address the elephant in the room, but also, I don't know what to do next. And that's what we're going to be talking about. Because asking means that you're going to have to receive, right? And so let's say you're brave enough to ask these questions, and now you got to go sit in that dark place with that person that Shawn talked about. You got to be sitting there. That's anxiety provoking, and what do I do with that, right? And so I think I encourage all of you, if you haven't seen this brilliant little animated short video that's put to Brene Brown's TED Talk piece on empathy and sympathy. It's very good because it talks about you don't need to know what to say next. You do not need to come up with the solution for their problem. All you need to do is connect with them and express gratitude. Thank you for sharing that with me. And it may actually mean, I'm not really sure what to say next, but I just appreciate your sharing that with me. And then comes the 80-20, because you're basically allowing them to talk about it. And that's what we do on the crisis line. So this is not just about asking, this is also about supporting. So the asking piece is the assessment. And again, this is not a difficult, detailed, complicated assessment. You can have one if you want it, but this is really about finding out what the risk is for both you and the person who is struggling with these thoughts, and then supporting them, and the supporting goes through the safety. And Shawn's gonna talk about safety planning in just a minute. I'm gonna address the assessment using this, the suicide severity rating scale. All right, now there's a number of versions, but primarily, let's look first at who can administer it, right? Well, we already said everybody in your role, you can do this. Well, guess what? You don't need any mental health training. You really don't. It doesn't need to be your background. Anybody can learn how to do this. And it could be in all kinds of settings, all right? And this is directly from the Columbia Lighthouse Project website. There's tons of training available. I highly encourage you, one of your handouts, there's a resources page to get more training on these. Especially if once you get a taste of the screening version today, you want to do the more in-depth one. All right? And I do think that we know that we had Kelly Posner, Dr. Kelly Posner, who created this skill. She was one of our keynotes a number of years ago, and I know that DMH has been implementing using this screener. But this is the screening version. I just want to point out, all we're trying to do so that you and the person who is thinking about suicide can work together is you're going to find out how severe are those thoughts. Do you guys remember how many thoughts of suicide, of that number that I had up earlier? It was really large, right? And the difference between that and acting upon it is huge. That should all make us feel better. We don't have to call 911 every time somebody mentions, I'm thinking about suicide, because there's a big difference between the thoughts and the act. Okay, let's go through these. Number one, this question you always ask, and you can follow along. You have a copy of this screen.
In the handouts that we gave you, you will see this. There's 4 different documents. This one has like kind of the colored bar on the side.
Yeah. Question number 1, and I actually really like this. I said to you earlier, we always teach it on the crisis line. Are you thinking of killing yourself? You gotta say it. But I actually think that kind of may close the door for some people who do not consider, who may have not even admitted it to themselves yet, right? That elephant in the room, lots of stigma, not talking about it. So let's look more into the passive piece of it first. Have you wished you were dead or wished you could go to sleep and not wake up? Okay? You get a yes or you get a no. Makes sense, right? And typically the time frame for these are in the past month. Question number 2, also always ask. Now you follow it up with, have you actually had any thoughts about killing yourself? Good transition, right? Because sometimes we address the fact that, hey, it's easier for us to say, you're thinking about hurting yourself rather than killing yourself, and how important it is to name it. I like the way this is framed. That wishing you did not wake up is different from actively thinking about suicide. Now you have 2 different questions. If you get a yes to question 2, you're always going to have to ask the following questions, okay? So now we're getting into question 3, which says right there, if suicidal thoughts are present. And that question is, have you thought how you might do this? I think that's really interesting, the way that is put, because I think certainly in the clinical world, we're just taught to like, what? They're saying they're thinking about suicide, I gotta ask about the plan and the details, and almost such a serious and scary thing. But I like saying, have you thought about how you might do this? Not as scary, but all you need is a yes or a no, okay? And if there is a yes and you saw that that was an orange, so the order is kind of like yellow, orange, red, okay? So the yeses that you get to the red questions means you're dealing with a more emergent situation. Question number 4, have you had any intentions of acting on these thoughts of killing yourself, as opposed to having the thought, but you wouldn't act upon it? Big difference, really big difference. Many people will say yes to question 3 because it's almost impossible not to think about. If I have suicidal thoughts, I probably have some ideas on what methods they're out there, right? But if I say yes to question 4, we're dealing with a more lethal situation that will require an emergency response. And the same is true for question 5. Have you started to work out or worked out the details? So now the more detailed the planning, the time frame, the how did they get the means, all those different things. If the answer to that is yes, we're dealing with an emergency situation. Okay, this is just the screener, right? And now you can probably, hopefully imagine how you can use this in any sort of setting. I can talk to my mom if I'm worried about my mom, if she's struggling with something. I can ask these questions. And it's not just for me, it's also for her. The final question we also always ask, even if the answers to questions 1 and 2 were no, okay? Have you done anything, started to do anything, or prepared to do anything to end your life? Now we're broadening the scope a little bit, and this is the sort of consolidated question about behavior that is in the screener version. The full version, we're looking at aborted attempts, or interrupted attempts, it's much more detailed. But now we're just finding out, what have you done before, okay? Pretty straightforward, right? 6 questions. Do you think you guys can all ask those? And you can probably remember those. And the reason those community cards are on the table is because you can make them even smaller and put them in your wallet. These downloads are available on the Columbia Lighthouse Project website. But you can also email me and I can give you the template that I designed so that you can make it in that particular format. But these are really cool things to have. It makes it so much more approachable. We keep talking about our roles, and it's a community, and it takes all these different puzzle pieces, as Ellie talked about this morning. Well, if we make it too complicated, it's not going to happen. This is how we can make it happen. All right, so we're gonna show you a little video.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself, so I was dispatched to her location. I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to C-SSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that, all right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Wow, that was quick, wasn't it? Now, it kind of did end abruptly, which that's just a clip I happen to have, but I wonder if most of you recognize something in what this young woman said. I don't have to go to the hospital or anything, do I? This is the reason why so many people do not reach out. And for those of you who work in the school system, oftentimes the kids who are struggling know that they may end up there, and that may be the reason why they don't reach out. What if we could create a safer environment for people to answer these kinds of questions more genuinely? Like she said, no, right, to question 2, more or less, but he still, and then when he followed it up with question 6, because you have to always ask that, she did indicate that she had done something some time ago, but that was in the long ago past. Didn't that change the way we looked at it? Well, I'm still going to take you to the hospital. I'm still going to put you on a 5150. Maybe that's not what's necessary. What's necessary is now we can start working with Joan, get her connected to resources, right? Makes it less scary. So within our systems, within our roles, family, friends, school, work, all of those different kinds of environment, make sure that you have a flexible response. If you're going to start using a screener like this, make sure you know what to do. You can always call the crisis line. That's one of the options that we're working on with the Mayor's Challenge as well. Just so that you build up a little bit of muscle memory, do one quick exercise. Look at your handout, and there's a vignette in there.
I hope nobody's name is Fred.
His name is Fred. Take just a minute to read through that, because we're going to go back to Fred. We're going to use Fred again when we do a little group exercise with safety planning. But right now, just take a few seconds to read through Fred's scenario. Okay? When you've done that, look at your page with the screener, pair up with a person sitting at your table, and just between the two of you, take 1 minute to practice asking the question. So one of you guys is going to be Fred, and the other one is going to be the person to ask the questions. Whatever role you try on, you will find you'll learn something from it. Okay, and you're just doing it on your own. You're not going to be, well, you are being filmed, but we're not going to hear that. So everybody read through Fred? Maybe just a few more seconds. If you are ready, just grab a partner and practice this quickly on your own, and then we're going to wrap it up and start with our safety planning piece. Okay, go. You have 1 minute. This is your time to try it.
So, experientially, what was that like for everybody to practice asking those questions? And also, if you were in the role of the person at risk, if you were kind of assuming the Fred role, what was it like to share some of those answers? Difficult? Uh-huh. Mm-hmm. Sure.
Already thinking about resources as you're asking the questions. That's good. That's really good.
Who else wants to share their experience? Maybe a couple more people. Yes, sir.
Do you guys hear that?
Sure.
So even as Fred, you found yourself wanting to say, kind of like downplaying it. Yeah. Yeah. Even though you know you were playing a role. Interesting.
I really appreciate you sharing that, because that really, I'd like to think that everyone in here is more aware than the average person about these issues. And that really speaks to how all of us have this internalized, unconscious set of beliefs and experiences that kind of make us want to go down a particular path, even when we know. And sometimes it's really important to be aware of that so we can use that to empower us instead of letting it guide us to a place we don't want to go. Thank you so much for sharing that.
Okay. So what she's saying is, even though he answered no to both 1 and 2, she still was starting to panic and really wanted to ask those other questions, because what if that wasn't a genuine answer? I do want to say something about that, though, because I do think it's true that people may not necessarily be truthful in their answers before you have built a rapport with them. And so I would recommend to trust your instinct, not to panic, hopefully, but to recognize that maybe this person needs to get me know a little bit better, and I'm a safe person to talk to so that they can give me a genuine answer. So I definitely am a big fan of trusting your instinct. It's the same reason why we did not have people who are, that's why people do not tell us about it. Okay?
I also want, what I'm hearing, also, I want to go back to that OMG slide where it's like, what do I do? Like, there's that fear. It's like, oh, I don't want to miss anything. I want to help this person. I don't want this person to die. And all of those things are going on in our head.
Yeah.
And so we have to manage a lot of different things, like in the heat of the moment.
I'd like to add, too, that if we just approach someone saying, I just have this feeling that I just need to have. I'm not here to judge you. I just want.
It's
Yeah.
very genuine.
And just say thank you for what they're telling you.
We're gonna have Nina ask a question, and then we're gonna have to move on.
So Nina is basically saying how important the trust relationship is. I think it's a little bit different in a friend or family setting, but if this is something that's implemented in your work environment and you want to change that, you want to show that you have that flexibility, you need to start it. That's as simple as that. You're modeling, hey, you can say you're thinking about suicide and we're not going to freak out. Then that's going to get more people. That's how we make the change in society. Yeah.
How's everybody doing? All right. I appreciate you all being with me. I know that we're talking about this really heavy topic, and so I really appreciate everybody's participation, and we're going to go ahead and transition now from kind of appreciating that the Columbia is one of many different ways that we can assess risk. Beck has a suicide severity scale. That costs money to get the form though, whereas one of the beautiful things about the Columbia is that it's public domain, so you can just download it, and the ease of use and administration is really unparalleled. And it's so...
Even the full version.
Yeah, it's really a brilliant instrument. But there are many others. I always think it's important, it's not so important what instrument you use as much as it's important what information you get. And so whatever you're more comfortable with. But this is one of many.
And we can answer some questions because we're running a little short on time. So we will leave some room for questions at the end because we started 15 minutes later than we were supposed to. So if that's okay, if you hold some of your questions until we're done with the SP.
So I want to start talking about something that some of you may be familiar with and some of you might not be. My goal at the end of our time today is that you have a really kind of solid introduction into what the safety plan intervention looks like. This was developed by Stanley and Brown, and it's really great. And I'm going to tell you why it's great. So one of the reasons why it's a fantastic intervention is because of the brevity of administration and developing the safety plan. So typically, a safety plan can be developed in 20 to 45 minutes. With my suicide attempt survivors, we usually spend about a half an hour together, and there's a pretty comprehensive safety plan that is formed. And I always tell people the safety plan is a living, breathing document. It's always open for modification and interpretation. PAR is an acronym that we use. It stands for person at risk. So if you hear me say PAR, please bear with me and know that I'm talking about a person having a suicidal crisis, a person at risk for suicide. So a safety plan provides a person at risk with a written set of 6 different steps that they use in crisis. And the steps are kind of in a gradient format. So they're prioritized and they are progressive in nature. And so kind of the first steps when we're talking about identifying warning signs or identifying coping skills, that kind of elevates all the way up to who are the professional resources, and in professional resources, we talk about different sources and resources like going to the hospital if you have to. We don't take hospitalization off the table, but one of the great things that D.D. Hirsch as an organization really focuses on, because a lot of people won't share their suicidal experiences with people because they're afraid of going to the hospital. I like to think about the safety planning process as an experience like going to the Cheesecake Factory, okay? And why I think about it like the Cheesecake Factory, I can say it to all of you right now. You all are so great. I'm having fun being here with you. Let's all go out to eat at the Cheesecake Factory. I don't know what any of you like, but there we go. Let's go. That's right. I don't know what any of you like, but the menu is so broad and diverse that I feel confident that most everyone could find something that would be satisfying enough that we could enjoy a meal together. The safety plan, you're creating a Cheesecake Factory menu. You're creating a range of options that go from having an appetizer to having a huge meal to having 30 different types of cheesecake, okay? It's all out there. It doesn't mean that in any given crisis situation that someone's going to eat everything on the menu or use everything on the safety plan. It means that you're creating a larger buffer. You're giving them more resources. We know that a lot of people are treatment resistant and they don't follow through with treatment recommendations or treatment plans. And so one of the nice things about a safety plan as an intervention, it's a standalone intervention. It can be used that way. And for people who might drop out of therapy or might not comply with treatment recommendations, they still have that, and it's been shown to be an effective buffer against making suicide attempts. And the nice thing is, you don't have to be a psychologist or an MFT or an LCSW to develop a safety plan. Stanley and Brown recommend some kind of professional medical-like background. So they say that, nurses can develop safety plans, crisis line workers, therapists. There's a large range of people that are able to create safety plans with folks. And so that's the good news, because we know that a lot of times, for example, people's first line of defense, they'll go to their general practitioner and they'll say, I don't feel good. I'm having stomach pain. And as a good doctor would do, and they explore what's going on, they might determine that someone's at risk for suicide, but not imminently at risk. They're not going to the hospital, but hey, let's give this person some resources, and primary care physicians can be trained and are qualified to help develop a safety plan if that's something that they want to build into their practice. I love that. So when we look at emergency rooms, because a lot of times people will be given a safety plan in the emergency room when they've come in for a suicide attempt, for example. So if somebody comes in to an ER and a suicide attempt has happened, or maybe they were brought in for an evaluation and a psychiatric hospitalization wasn't indicated, the way that the system works right now, and this kind of goes into what Ellie was talking about, when we think about things systemically, right now, the system really works with this just assess and refer model. Hopefully there's some kind of safety plan, but that's not a given by any stretch of the means. And so people are given with this list of referrals, and it's like, here you go, call this person, get therapy. We have a social worker who can help you, call them and make an appointment. The problem with that is that many people at risk don't follow up. They don't follow through, and so the referrals aren't very helpful if they're not using them, right? And we also know that suicidal thoughts have an ebb and flow to them. And so someone might be more motivated to follow through with a resource when they're in this intense period of acute crisis. And then the current crisis might kind of settle down a little bit, and they're like, oh, I'm fine, I don't need to do this. And then, what do they have if they don't have a safety plan and they're not going to engage in therapy or seeing some kind of resource? And so that's one-time intervention can be so powerful, because once they have it, they have it. Particularly, we like this app called the My3 Safety app because it's on your phone and it's like electronic. I'm going to talk about that in a little bit. So we know that people can always have it. I want to go to statistics right now a little bit, because no presentation is complete without a little bit of stats, right? Keeping in mind the goal of why a safety plan intervention is so important, and keeping in mind that, Stan and Yana said that we have till 12:15. Could you verify that? They said since we started at 4:85, we have. I just want to make sure, because otherwise, this isn't going to be what I want it to be. All right. So with that being said, 11 to 50% of people who make an attempt, they refuse outpatient treatment. That's a wide range, of course, but I think the take home of that is not to focus on the numbers so much, but to know that a lot of people aren't going to pursue any kind of outpatient treatment. And of those folks who do, 60% attend only 1 week of treatment and then they drop out. That's a large percentage of people who are not getting sustained longer term care. Of attempters who do actually follow through and engage in some kind of therapy, there's still 38% more of them who only stay in therapy for about 3 months. And so we know that things like fear and shame and stigma and a lack of access to resources can really hinder and decrease engagement in seeking treatment. So what we do as part of the process to increase the likelihood of people using a safety plan, knowing that a lot of people who need more, are we good? All right. Man, That was just like 5 degrees of anxiety melting away. I don't know if you all saw that, but it happened. Whew. Okay, so we know that a lot of people aren't going to pursue longer term, more intensive treatment that they might benefit from, but we don't want to just leave them with nothing. The safety plan intervention is really helpful. And in order to have a safety plan be good, the person has to be willing to use it. And we know that there are some ways to help develop a safety plan that increase the likelihood of it being used and of it being useful. And there's some other ways that kind of decrease the odds that it would be a helpful tool. Because to me, like, this seems so straightforward. It really does, but it's not. A safety plan is not really a safety plan if someone's not going to use it. It's only as good as the degree to which somebody feels comfortable and willing to use it. So we want to really engage people. We want it to be a collaborative and transparent process. And so one of the ways that I do this, and kind of thinking in my psychologist brain, I have anyone who's physically and cognitively capable of doing this, I actually give them the safety plan form and I give them a pen. And I'm like, I want you to write this. Not only because there's like this pride that someone can take in actually making it, but we know from different learning theories, there's this theory called the dual coding theory. And when people are talking through things and they're writing things down, they're internalizing it at different levels. And so they're more likely to buy into it and more likely to use it. Because again, it's not a safety plan if they're not going to use it. So right now, the safety plan intervention is used in a variety of settings. So ER departments, crisis hotlines, inpatient psychiatric units, different types of trauma centers, VA, health service centers, college counseling centers, a lot of private practice therapists and community mental health centers use it. So this is being used in a variety of settings by a variety of people. One of the main goals, and this kind of goes back to what Stan was talking about as far as hope goes, one of the main take-home messages that we want people to walk away with a safety plan is that when they are in that dark place, this can be a reminder of hope. Whether it's the coping skills that are identified that I'm going to talk about, whether it's the support system, whether it's the professional resources, there are other options beside death or life. There's safety for now, and there are different ways we can get there. In our Survivor of Suicide Attempt support group, in our second to last week, we dedicate that whole entire meeting to creating a hope box for people. It's really powerful and empowering, and when people get in that dark place, it's nice to have this concrete, symbolic reminder that, hey, there is hope.
Hey, Shawn, can I add something to that
I guess
before
so.
you start? Do not do the poll yet. I learned through my work with the Department of Defense and the Veterans Administration that they have something similar. They call it a hero box. So for those of us who are gun owners, this is our lockbox. We put the gun in it, and on top of it, we put all these hope items, right? So that if a person who has a gun is struggling with wanting to stay alive, they have to go through all those hopeful items in order to get to the gun. And that is, I love that technique. It's really helpful. I just wanted to share that because I like it. Yeah.
Okay, so for this poll, we want you to participate, and we're asking you to choose the response that is not.
I asked them to wait. Look at
associated
that.
with it. But people are so excited, Sandri. What can we do? So we want you to choose the response that is not associated with a safety plan. So is a safety plan collaborative? Is it progressive in nature? Is it a set of resources? And is it something that's purely clinical?
If you gave the wrong response, you can do a redo. It allows you to do that.
So, we're not necessarily here to talk about a hope box, but basically, in the week before, we ask people to bring in things that they're aware of in their lives that can fit into like a small box that remind them of hope. And so a lot of times people will bring in pictures, they'll bring in like a little trinket, they might bring in a book. I give them books and different kind of printed resources, and sometimes I'll give them like a little trinket also. But if you email me or call me, we have our cards that we can hand out to you at the end. I could talk about a hope box for a long time. So it's fascinating, and I want to throw this poll out because it is clear that this was not asked in the way that we wanted it to be, because 87% of you are identifying clinical, and we were hoping to identify that it's not something that's purely clinical, although it has clinical use. A safety plan is a collaborative document, right? And we did mention that it's progressive in the nature of resources that are provided, and there are resources that are embedded in the safety plan. It's not something that's purely clinical, although it is clinically used and clinically relevant. I want to change that. So with that being said, so I want to just go into the safety plan now. Because
we fought over this one, I think. Or no, we just didn't come. We'll figure it out. It's the first time we're using the polling stuff. It's cool, right? Yeah, I like it.
So the first of the 6 steps, this is the D.D. Hirsch version. There are the thing about the safety plan is that it can be adapted to a variety of different settings. And so this is the D.D. Hirsch adaptation. I am happy to send this out also in an email if you want. If you just take my email and send me an email, I'll send you the PDF so you have the template. This is how we adapted it for our needs. And so the first step of the safety plan, and again, in a collaborative nature where the person at risk is identifying as much as possible, we want them to identify the warning signs, or what to me is unfortunately referred to sometimes as triggers. I think that it's interesting that we call warning signs triggers when we're talking about suicide, but that's a topic for another day. So we look at triggers, and triggers are not universal, although there are some triggers that are common amongst a lot of different people. But we want to know, before suicidal thoughts happen, can you identify thoughts, feelings, situations, ways of thinking that are happening for you that increase suicidal thoughts, the duration of the thoughts, and the intensity of the thoughts? And we just have them, like for me, bullet points, again, another unfortunate term when we're talking about suicide, but we just in a real brief form, just really have them identify them and list them in an outline. And keeping in that progressive nature. So, because sometimes the thing about warning signs is sometimes we can just avoid them. If we know that going to Subway to get a sandwich is triggering for people, then don't go to Subway. There's some things that we can adapt to in our environment to reduce those kind of triggers. There are other things like, when I don't sleep, I feel triggered, that we can't necessarily avoid, but we can develop coping strategies to manage when those happen. And so we progressively get into step 2. And we talk about internal coping strategies. Internal coping strategies are things that people can do on their own without needing anyone else or anything else necessarily. Some examples can be reading a book, playing games, exercising, petting your cat.
Well, for some people in this room, that was a stressor.
Surprisingly, but yes. You know what? Again, some things are going to help some folks and some things are going to exacerbate problems. This is why it's a personalized kind of experience. A lot of people like to journal and just kind of note, this is what's happening for me right now. Those are all really healthy, helpful ways that people can cope. Well, let's add it. Definitely music. Now, external coping strategies, I want to define this from the 4th step that's going to be coming up. So with external and internal coping strategies, these are things that people are doing to distract themselves from the suicidal thoughts. Whereas So here we're identifying people and places where natural kind of environments for socialization and social contact and distraction are likely to occur. So you go to the gym, you go to the beach, you go to church, you go to Starbucks, and the social environment and being around people and noise and activity can kind of be a temporary distraction. And we know that putting time and space between suicidal thoughts often reduces the likelihood of someone acting on them. And so when we can distract, we're putting time between the thought and someone potentially acting, and that decreases the likelihood of them making an attempt. So here in step 2 and step 3, we're not necessarily telling a person. So if we're saying, hey, I'm going to go to get coffee with Pam or with Nina, it doesn't mean that I'm going to coffee with them to necessarily talk about my suicidal thoughts. I might just be going to talk about random stuff that's going to distract me. Whereas in step 4, we have people identify folks that hopefully are aware that suicide might be a struggle for the person and that they feel comfortable saying, hey, I'm thinking about suicide right now. I'm really having some difficulties. Can we talk about this? Can you help me? The people in step 4 might be the same as in step 3, but they may be different. Something that I want to really point out and be clear about, we know that through a lot of different mental health concerns that people have, that they tend to withdraw and isolate from people, right? So we know that. And so when you ask somebody to identify people to be vulnerable with, this could be very challenging for them. And what we want to do here is not to reinforce stereotypes that bring shame and stigma. We really want to normalize this that, hey, in my experience of working with people developing safety plans, this can be really challenging for a lot of people to identify folks. Let's do the best we can, and then during future times together, let's see if we can generate some people who might be here. Because a lot of times through isolation and withdrawal, people have this perception of being a burden to other people, which is kind of embedded in that isolation and withdrawal. Although in reality, it's almost never the case that the other person experiences them as a burden. And so with time and help, sometimes clarity can set in and people are like, oh, you know what? I can call my mom, or I can call my boyfriend or my girlfriend or my wife or my kid or whatever. Well, you can only you can do what you can do. That's step 5. So it's okay if you can only do what you can do. But that's why there's 6 steps and we're creating this Cheesecake Factory menu. So we go into professional resources. And here, this is if they're in therapy, we're listing a clinician. If they're seeking psychiatric services, we're having the psychiatrist listed. We're putting the local emergency department. Any good safety plan should definitely have the National Suicide Prevention Lifeline on it. Now, there's other professional resources that might be appropriate for a person given a particular circumstance. I like to include an urgent care if that's near their house. I like to include a psychiatric hospital in specific if that's near their house. And, this step also, you might have to be more kind of involved, and you might have to kind of increase your directiveness because you're going to kind of know these professional resources probably a little better than the person who's at risk would, except for like the ones that they're already using, of course. And then step 6 is all about means restriction. And so with means restriction, we've asked and we've assessed if there's some kind of a plan and if they have access to means. And if somebody does have access to means, this is where we come up with a plan to restrict them. So does somebody need to give a gun over to a family member or to the police department or to some other safekeeping? Can it be kept in the house with a gun lock? Some people will put it in a freezer and kind of restrict it that way? Do people need to have a family member distribute their medications to them? Do they need to work with a pharmacy to get a smaller amount per filling of a prescription? And we really work through this to identify what this is. Now, somebody can have 10 suicide attempts. They might have involved attempting to overdose on pharmaceuticals every time. We always ask about a gun, because we know that about 50% of suicide deaths are caused by firearms, and we also know that firearms are the most lethal means that somebody can use in a suicide attempt. So even if there's no indication from what the person has disclosed to you that there's a gun, we always ask, do you have access to a firearm? Because if they do, we really want to address that. And so, kind of moving on to wrap this up and just try to give you a couple minutes for an experiential exercise. It is a collaborative and co-created document. It's really essential that the collaborative spirit is adhered to for the safety plan to have a high likelihood of being used. The My3 Safety app, which I'm going to show you what it looks like, if you go to your app store on iPhones or Android and type in My3 Safety, it's a free, my and the number 3. That's what it looks like. And so they can download this, because I know like the paper form, people might spill something on it or leave it in a pair of jeans or leave it in a purse, and you really want to be able to have it accessible, because you never know when someone's going to need to use it, right? And so the thing I like about My3, it's on your phone. Everybody has their cell phones attached to their hips nowadays. They're more likely to have it on there. And another cool thing is that it's electronic. You have one-touch dialing to the 3 people that are your people, one-touch dialing to the crisis line, one-touch dialing to 911.
Or if your internal resource is listening to John Denver music, which was one of the ones from our more established callers, it will play it for you. So
And
perfect.
also another cool thing, on the paper format, it's a little harder to change, because Ella Morrison might be the best support right now, and then tomorrow she might be a trigger, and so we might need to change her out for someone else. And you just click edit and you can change someone really easily. We really like it. We want to assess, once we've gone through the 6 steps, whether the person's going to use it or not. And so we ask questions, and we might say to someone just very generically, what are the most helpful aspects of the safety plan? Is there anything on here that you think that you might not use?
And I want to make sure that you guys understand that you can do this with a family member or a friend, right? You can pull this app out and you can really do this. We're Shawn's speaking from a more clinical experience, but it really can be done in any setting.
We really want to identify and explore ambivalence, because that gets in the way of people using it. And again, a safety plan is not really a safety plan if someone's not going to use it. There is the My3 Safety app again. If you are interested in being trained how to develop safety plans, you can contact Stanley and Brown, which they encourage people to do. There's a resource page in your packet that has their contact information. But typically what a training looks like is that you download the safety plan manual and you review the instructions and the safety planning form. Then you attend a training and you learn about the empirical basis and the rationale for why a safety plan is helpful. And then you practice implementing a safety plan through role plays. And so I'm happy to stay if you guys want to do this for a couple minutes. If you want to go eat, I totally understand.
We also have a little end poll here. So maybe this,
We're going to skip the poll though, just for time.
Oh, okay.
But for the vignette, there's that Fred vignette. If you guys want to take 2 minutes, 3 minutes at your tables in your group and just kind of start formulating what a safety plan might look like for Fred. If you gotta go, you gotta go, I get it.
You can put up the poll so they can also do that at the same time.